Good evening. The doctor is in. How are you, Mo?
Good evening. How are you?
I'm great. We're not together anymore, Mo.
I know. I miss you. I miss your
I
face.
miss
I
you.
miss all of you. I miss interacting with people. You know, it's just isolated, and I'm an introvert. Even I'm having a tough time.
I know. We were together on Sunday, and it was so great to like be in the same room in the same place with people around us. We had masks on. We were socially distancing, but
Mhm.
I think there's going to be more of this pandemic, so we got to get used to the Zoom thing, right?
It's true. And it's a good thing to connect all of us. I mean, how else will we have all these amazing people in one room at the same time, bringing them all to you in your living rooms if we didn't have this wonderful technology? So,
Right.
you know, we're just so excited to get all of these wonderful folks and wonderful stories and get this information out to you. Ricky, you want to tell us what's our topic for today?
So our topic for today is no, you are not too young to get breast cancer.
Wonderful folks and wonderful stories and get this information out. I
Yeah.
love it.
And so, and you know, the data says that Black women under 35. So the mammogram recommendation is age 40, right? Black women under 35 get breast cancer at twice the rate of white women and die at 3 times the rate. And we do not want that to happen. And you know, we talk about it all the time. Our disease is different. Black breast cancer is different, and we need to handle it differently, address it differently. And we need to start young. We need to talk about it young. We need to talk about it at our kitchen table, as we talked about last week. We need to talk about it young. To me, as soon as you go ask for birth control pills, you should be checking your breasts. So that's what we're going to talk about today. And we have some great guests, Dr. Mo, like all my breasties and friends.
Yeah.
So why don't we do like just a quick go around introduction, hello, and then we'll jump right into stories.
I love it.
So Ari, you go first.
Hi, my name is Ari. I'm a 2-time breast cancer survivor. I'm only 21 years old. I was diagnosed the first time at 19. I got a double mastectomy, had 16 rounds of chemo, and it still came back for a second time. I like to share my story just to let people know that cancer does not discriminate. People always think that it's something that comes later on in your life, but it actually does happen to younger women. And like Ricky was saying earlier, like a lot of the younger women tend to be African-American women. So I would like to spread my knowledge to everyone else so that they can be informed about their bodies and everything.
Awesome. Shantae?
Hey everybody, my name is Shantae Drakeford. I am a nurse practitioner. I've been a registered nurse now for probably 12, 13 years, and I'm an Army spouse. I am from Washington, D.C. originally, and I was diagnosed at the age of 31 with stage 4 metastatic breast cancer as my initial diagnosis that has spread to my lungs, some spots in my spine, my hip, my rib, and I was having actual symptoms since I was 25 years old. And I've been advocating now for probably 4 years because there is a lack of youth that is involved, and we just need proper education and just awareness. So I'm just here to share my truth.
Awesome.
Welcome. Thank you.
Dr. Lori?
Hi, everyone. I'm Dr. Lori Wilson. I am Division Chief of Surgical Oncology at Howard University Hospital. I'm also one of the wonderful responsibilities I have is that I'm Program Director of the General Surgery Residency here. And so I'm in charge of 33 just awesome young surgeons who will go into being the next generation of surgeons. I was diagnosed with breast cancer in 2013 with breast cancer in both my breasts. I underwent chemotherapy, double mastectomy, radiation. I actually had a reconstruction that I lost because of a bad infection. And my story was told by the Ken Burns documentary, Cancer, the Emperor of All Maladies. Currently, I am lucky to be the mom of an 8-year-old who is rambunctious and the wife of a wonderful person from Puerto Rico. And so my job here hopefully is just to share my story and things that have happened oh, I'm sorry, I didn't tell that actually I had a recurrence of my cancer in 2019. So I am currently stage 4. But I am a big push. I push hard for clinical trials because I jumped in on a clinical trial and all my disease has almost gone away. So I'm really blessed to have the opportunity to be here and just to tell you about my story.
Badass press.
Awesome. Representing HBCUs.
Yes, yes.
Dr. Fairley, I think you're my cousin girl.
I think so. We're going to claim it, okay? Hi, everybody. I'm Dr. Tamika Fairley. I am a senior health scientist at the Centers for Disease Control and Prevention, where I lead our work to address the issue of breast cancer in young women. And I've been doing that for about 10 years, give or take. And so I think we've made a little bit of progress that I hope to talk more about here. And on this panel, I'll share some, but I really am hoping to kind of listen, and I'm really honored to be on the panel and hear the stories that are being shared here so far.
Thank you so much.
Dr. Gori.
Hi, my name is Agori Kalu. I'm a breast surgical oncologist, primarily practicing in the Newark, New Jersey region. I've been a breast surgical oncologist now for about 10 years. Time just flies so quickly. Practicing within the same area, Newark, New Jersey, suburbs of Newark. I was formerly director of breast surgery at Rutgers, New Jersey Medical School in Newark. And I left to basically be more independent as a private practitioner, also have time to committing to breast health education within the community and international medicine within the diaspora, again, promoting breast health, breast education, and the like.
She left her cushy job to be with her people.
Absolutely.
Right.
Dr. Kelly, don't we have history here? Didn't we talk not too long ago?
Yes, yes.
Oh my God.
Yes.
I love it.
Yes.
So, wow, look at these amazing women, right? Amazing
It's
women.
incredible, you know, and I want to share one more factoid that is so, it's interesting to hear it, and it makes sense when you hear that 80% of young women find their own breast cancer, right? And it makes sense because they're not of screening age. But what that says to me is that maybe only 20% or so are getting some sort of screening, like they know their history, they know they're at risk, they know they have a mutation, and they've actually gone through that process to see, well, maybe when should I start screening? And I think that that's something we want to touch on later in the talk, because maybe those numbers could look a little bit different. But, you know, for the majority of young women, there isn't always a family history, right? There isn't always a warning sign. And, you know, these things can happen. And so I definitely want to hear the stories, and I want you guys to tell us more about your experiences and things that you've learned and things that you want our viewers to definitely know. So by all means, we're going to start with Ari, aren't we?
Yeah.
All right.
How'd you find your cancer, Ari?
So I actually stumbled upon my cancer while I was shaving my armpits in the shower. So where your breast and your armpit meet, your talus, that's where I kind of felt it at. And I feel like growing up, people always talk about like lumps and things, but nobody ever tells you what a lump actually feels like. And so when I felt it, it felt like a rock. And as soon as I got out the shower, I called my doctor's office and I was like, yeah, I need y'all to do a breast exam, because I do have an extensive family history of cancer. And I also have the BRCA gene mutation within my family. And so I went in, got the breast exam. Then that's when they ordered the biopsy. I went and got the biopsy done. A week later, sitting in my room, just made a Totino's pizza. I was about to go to class, and that's when I got the phone call that I did have breast cancer. And so my first steps with that was just, you know, going through chemotherapy. I was not recommended to go through radiation therapy because when they did do my genetic testing, yes, I came back positive for the BRCA gene mutation, but I also came back positive with the TP53 gene mutation, which is TP3 is in everyone's body. It's the cell that helps like fight off cancer cells and stuff like that. And so my body does the complete opposite. So they think those two combinations of gene mutations was the reason why I was diagnosed at a young age. So I did go through 16 rounds of chemo. I went through 4 ACs and 12 Taxols. And I'll tell you, the Taxol felt like water compared to the AC, because the AC was extremely strong. Patients usually refer to it as the red devil, and it is the devil. But I will say I did get a lot of good sleep out of chemotherapy. I will say that. Then after I was done with my chemo rounds, I did go through a double mastectomy, and I was in remission by September of 2019. But unfortunately, this year it came back in May. Once again, I stumbled upon it just because, you know, I regularly check my breasts, just because, even though often people think that once you get the double mastectomy, you're A-okay, but it's still possible for it to come back. And so it came back. Now I'm on 6 rounds of chemo. I end next week. Woo woo. And this chemo allowed me to keep my hair. So that's super exciting for me too.
Yeah.
And I feel like that was honestly one of the hardest parts about like getting treatment, because you know, you're a woman, and I'm also in college. I'm a full-time college student. Ironically, my major is radiation therapy. So there's a correlation, silver lining between it all. So I really feel like I can connect to my patients, and they feel a lot more comfortable telling me things once I tell them that I'm also a survivor. So I get to see like 2 different aspects of being a healthcare worker and being a patient. So I feel like I'm a lot more sympathetic towards patients, and I listen to them a lot more than other health professions do. But yeah, so now I'm going through my 6 rounds of chemo, and I did have 2 surgeries this summer. I just got a lumpectomy, and then at the end of the year, I'm gonna start radiation. And yes, I do go to clinicals all day. So I will be at clinic all day, and then I will be the last patient of the day. And I just love to show people my drive and determination. And just like with Chadwick's death, you know, the Black Panther, like it was so unexpected to everyone. And I just want to also tell people like cancer patients look like just like everyone else. Like nobody would ever expect that I'm literally battling cancer right now, but I am. And I just feel like if I could do it at 19, 20, and 21, anyone can do it, you know? So I really tried to give back to my community and inform young women. I've gone and talked to girls in high school and tell them about like examining themselves. I try not to put a fear in their minds, but just more so of knowledge and information. And yeah, I'm also a part of an organization called Be the Match. It's a bone marrow registry for people that have blood cancer. So we recruit a lot of people. I'm in the Texas State chapter. We're actually one of the largest chapters that signs people up. Like, for example, one of our trips, we had 3 days to sign up 500 people. We ended up signing up 1,500 people. And so that's 1,500 people that can possibly cure someone's blood cancer. So I like doing things like this. I love this web show, showing people that young people can also be affected by this disease, and that it's actually really true. And it's not as rare as some people may think that it is. And so, yeah, that's my story.
So Ari, did you have a double mastectomy the first time, or just partial, like a lump?
Yeah, I had the double mastectomy, and then I got the reconstruction like 4 months after. So I do have the implants, but
Right. So where was your second cancer? Can I ask? Like, where'd you?
So the first time I had 2 tumors. I had one at the top right here in my toes fence, and then one at the bottom. And so this next one came back in a completely new area. It was like over here. So that's why they're like pushing radiation this time, go around, and they're hoping that I don't get a second cancer. But I know my God is great in that. I went through this second journey to be able to do things like this, because I was not offered any of these opportunities the first go around, you know? And I feel like I learned a lot of new things in my second journey. So I feel like it was meant to be. I take the situation as it is. I try not to be in a victim mindset, pretty much, in a victor mindset. So that's my story.
Go girl. You go girl. I love you.
Incredible.
All right. So my little baby child. My baby child.
Listen, I look young, but I'm not that young. Oh, okay. All right. Hey, everybody.
Take it. Just own it.
I own it. Okay. So I'm a medical professional. I've been a registered nurse, and I have never been afraid of being aware of my body and finding anything I can early.
Mhm.
And when people hear stage 4, you hear instant death, right? And people don't understand that stage 4 and metastatic are actually the same. And what does metastatic mean? Metastatic means that the breast cancer has spread beyond the breast. And I'm grateful that it's like a silver lining, right? So I have envy for those who are early stage because I feel you could get on with your life. Of course, you have some side effects, but for me, stage 4 is lifelong, and I'm gonna be in treatment forever. But there is a big quality of life standpoint with this. I was 25 when I was having symptoms. I had nipple discharge. I had fibrocystic breast, meaning like my breast tissue was dense. I had lumps, which they saw it was cysts, and they would give me ultrasounds every 6 months. That was all I was able to get. I never was offered any type of biopsy. They would never give me a mammogram. They were like, "You're young, you're not going to get cancer, you're fine, it's nothing." And I had like, they was like, as long as your nipple discharge doesn't turn bloody, it was like a yellow color. They was like, as long as it doesn't turn bloody, you're fine, it's normal.
Wow.
That day came, it turned bloody. And I truly believe that when I got that surgery to remove that breast duct, they said it was a benign tumor in there called intraductal papilloma. And I had like a really large cyst at the time. It was very soft and very movable, right? I never was offered a biopsy, but it was very tender when I was having my periods. And they say you could get cysts on your periods, but my cysts stayed all the time. And I asked them, could they drain it for me? I came out of surgery, that didn't happen. A few months later, they told me I was having a lot of pain, and it was like, it's probably scar tissue. Take some evening primrose, which I know now that's just even going to feed it more because it's hormone sensitive. I am triple positive, meaning I have heavy estrogen, progesterone sensitivity, and the receptor HER2. So I'm actually 95% sensitive to estrogen, progesterone. So even the primrose probably just made it grow more. And then like that lump became very hard and like a rock, and I knew something wasn't right. So I just kept going back, and I was like, something is not right. I need to be evaluated. So they sent me to get an MRI actually. And the MRI is what diagnosed me. So the thing is, they came in the room and I still thought it was another benign condition. And they was asking me all this, asking me about my history, my family. I don't have heavy family history of breast cancer. My great aunt had it, and my aunt was diagnosed with stage 0 DCIS right like a month prior to me, but hers was during a screening of mammogram, right? But they don't screen young people, and we're almost like the forgotten group. So you got the young cancers, and then you have people who are older than 45, and then it's us between 15 and 39, and we're kind of not like evaluated as much, and we kind of dismissed sometimes. But that's when they saw an abnormal lymph node, and from that they was like, well, we're going to do a whole body scan just to make sure it didn't leave. They call it a bust. Like it, doesn't necessarily mean the bust left, but we want to make sure. And they was asking if I had any other symptoms. Me, I was thinking it's normal. Like I had hip pain, and I thought I had sciatica. I had a cough. I thought it was allergies. I had lower back pain. I was going to the chiropractor. I thought it was back pain. And I'm a medical professional. So I didn't really connect the two. And when I had a whole scan, that's when they found it in my spine, in my rib, in my lungs. And in my rib, I thought I injured myself because I snowboard. I thought I injured myself. And then my husband and I, we were going through infertility, right? When you're young, you want to have children. I've been with my husband since high school, and we was at that point where we was planning to have children. 5 years we tried. I was on the Clomid, the Letrozole. I ended up having endometriosis, had IUI, IVF, and that year prior, I had IVF. It was not successful, but it makes me think that all those hormones I was injecting myself made it grow very rapidly. And then I felt guilty because, they say if you got stage 4 and you got an 8 centimeter tumor, you was obviously ignoring. No, I tried everything to get screened early and catch it early. And that was my initial diagnosis. And I just know that for sure that the medicine I was getting for fertility had made it grow. And now I can't have children. I was denied adoption. These are things that young people, we want children, but they've said, since I'm never going to be in remission, that, I can't adopt, but I have a stable husband, and I was a foster child growing up. This has always been in my plan, and it just was devastating. But I know that this is my purpose, just like Ari was saying. I've been through a lot, I've been through deployments with my husband, and I just think that I have the strength and power now to share my story, and I want everyone just to be aware and just advocate and get second opinions. And you're never too young to get, breast cancer, and we just get diagnosed at later stages, especially as African Americans and young people, double the time, just like Ricky said. I don't know, it's a lot. So,
Nurse,
Wow.
nurse,
Wow.
you get great quality care with the military, and you're a nurse.
yes.
And that's another thing, you guys got dismissed by the doctor, and you were talking about, so God.
That's not all you do, though. What else do you do? You left out some things.
Okay.
Come on.
The fun stuff. All right. Okay. So I'm a farmer, right?
And
And what's the other one?
You're
Oh, I have bees. I just have bees. So on my farm, I have chickens, I have ducks, I have bees. And it just kind of came out of nowhere. I'm from DC. I never thought I would do this. And I've lived all over the place. Like I lived in Alaska, Washington State, Georgia, because my husband's in the military, Korea. And so I got exposure. But I came back to this area, ironically, at the same time my husband was transitioning into the reserves. That's when I got diagnosed. And so we honestly was going to move back to Washington State. That was our place. But then I love my providers here. I tell my providers, I'm like, you can't leave, you can't retire, you can't die, nothing can happen to you because you gotta treat me forever. Who's gonna take care of me? I love them. So we decided to find us like a nice little house on a historic property. We gutted the small little house. We always wanted to go tiny. We're very, unconventional people, right? And we renovated the house and gutted it inside out. And then I have a 2-acre lot. And I mean, what am I do with 2 acres of land? I gotta do something with it. So my husband and I, we just like started growing stuff. I got like a big field of greens. And I mean, it's my joy. You gotta have, like Ari said, a silver lining in this. Yes, it sucks. Yes, I have stage 4. Yes, I'm in pain. I have nausea. I had to get radiation. I was on crutches for like 5 months because my hip could just snap. And I'm scared of progression. I got to get screened every 3 months just to make sure the cancer doesn't spread or don't spread. The medicine I take is at bay. So I have my hair because it's oral. I take oral medication. And any medication is chemotherapy. It's a chemical therapy to stop the cancer from growing. It's not always IV. I won't get to ring the bell, but I have to find a quality of life, right? And I'm trying to do as much as I can now while I can. And I still work. I went back to school. I was in the middle of my nurse practitioner program. I went back after 2 years of kind of stability and just went back, did the clinicals. Oh, it was rough. But I'm a nurse practitioner now. I'm able to work like once a week and still help people. I'm helping my people in an underserved community. Yeah.
You go, girl. You go.
Wow, your story is so amazing. And I feel like it just shows how African American women get brushed off all the time in the medical field and nobody gets taken seriously. And wow, that it makes me so mad. Like it makes me want to write you a big giant check because you deserve a big giant check.
And I'm a Bowie State graduate. Okay, BSU. I'm just saying.
We're gonna talk about the HBCU in a second. All right, take a deep breath. Whew. Dr. Lori.
So, let's see. I was originally diagnosed in 2013. I was actually my son was a year old, and I stopped breastfeeding and, doing all the things healthy things that we were supposed to do to sort of take care of yourself. When I stopped breastfeeding, what I found was that one of my breasts didn't go down as expected. And so, I do this for a living. So I knew that it was serious. The one thing I honestly did expect to hear that I had breast cancer, but what I didn't expect to hear was that I had breast cancer in both breasts. And so when I look at my story, it's very interesting. I actually also underwent fertility treatment for my son. And so when I think about the impact that potentially could have had on the growth of my breast cancer during that time, just right up until I was pregnant. And then I got pregnant and then ultimately breastfed for a year and then stopped breastfeeding and then had the diagnosis. I had two different types of breast cancer. In my left breast, I had a triple negative breast cancer. And in my right breast, I had an invasive lobular, which is pleomorphic, which sort of is a bad actor all on its own. And I was ER/PR positive, HER2 negative in my invasive lobular, and I was triple negative in my invasive ductal. And ultimately, went through having bilateral, I underwent chemotherapy first. I did ACT. Ultimately, the triple negative breast cancer went completely away, and I only had millimeter of breast cancer left of the on the left side. I also had complete resolution of the cancer because I had one lymph node that was positive. And so all of that ultimately went away. We went on to do radiation of my chest wall, radiation of my, on one side, and then ultimately went through reconstruction loss because after I did my radiation. And that was a bit disconcerting for me because, I'm a healthcare provider. And at some points, you get really tired. And it was one of those really low points for me where I knew something was wrong, but I was like, whatever, okay, whatever you say. And the doctor was like, no, it's not a big deal. I think it's fine. And ultimately my wound opened up within 2 days and poured pus. And I ultimately was in the ICU for because my blood pressure dropped and I was really ill after that. And, I hardly ever talk about that because I should be able to, diagnose these things in myself. I should not have let my guard down. I should not have let someone tell me that it was the right thing to do when I honestly knew that it was not the right thing to do. I was just so ultimately tired at that point.
You're only human. You're a superhuman.
Yeah. And ultimately, we went on to, was on tamoxifen, and then I changed over to another medication because of side effects from tamoxifen. And I was on a vacation, and it's very similar in that I was having back pain from after the vacation, and I thought I just, hurt my back from carrying all the luggage and doing all the things that we had done because we had gone on a cruise. And what I found out was that my cancer was back, and my cancer was back in my bones and my liver. And I went on chemotherapy. I did radiation for my disease, and then ultimately found out that though each month I was doing okay, my disease was still kind of increasing in its amount. And so I decided that I had to do something that was either aggressive or I was going to lose my window. And so I decided to do a clinical trial. And within 3 months of being on my clinical trial, 85% of my disease is gone. I have a 1 centimeter area in my liver. And I'm blessed and thankful that I actually was able to be involved in a sort of cutting edge immunotherapy, as well as targeted therapy, targeted therapy that allows me to live a really amazing quality of life. I'm blessed to be able to take care of patients. I still go to the operating room. I'm full-time, honestly, and I feel amazing. And so for me, it's really about giving back to my community, making sure that I am stepping up and voicing my opinions, and that we are being heard for the things that are necessary for the patients that I serve. So
That's incredible.
Awesome, incredible. Dr. Lloyd, how old were you when you were first diagnosed?
I was 40.
You know then it's a 40 thing, right?
Yeah.
Okay.
I want to hear from Dr. Fairley.
Dr. Fair.
Wow. I think I was waiting for Ricky to say, take a deep breath. I was like, I need a deep breath. Hold up. Yeah, when I first started this work almost a decade ago, one of the first and most prevalent stories I heard from young women were, I went to the doctor, I had this thing, this lump, this rash, this something. They told me I was too young to have breast cancer. They sent me home. I went back to the doctor 3 months later, because this thing, whatever was going on, got worse. And they sent me back home. When I went back the third time, I was diagnosed with stage 3, stage 4, et cetera, et cetera. And this was a very common story. It was interesting because I had a lot of resistance from the clinicians who were around me with that, and just kind of hearing the truth of that these young women are coming in, presenting, and not having their symptoms worked up, not having a full workup for the lump, the rash, the whatever. And it still happens. There was a lot of resistance to that, because I work in the data world. They're like, well, where's the data? Is there like a study? Who's got the surveillance data from that? And I'm like, yeah, okay. But the fact that I still hear this story now, some 10 years ago, is tough, for me to hear, and it's really disheartening that it's still the case. One of the things that so what I work on is a congressionally mandated project called the Early Act. It was enacted in 2010 and led by Representative Debbie Wasserman Schultz. And one of the big pieces of that was addressing healthcare providers, and it was, you've got to get to the healthcare providers because they are first line, they're front line. When young women come in, you've got to get to them with the right information. And it's taken us a while, honestly, to get to that for a whole bunch of reasons, some of which being, people not believing that it was the doctors, but the other part being the doctors not believing it's the doctors, and really trying to work on the education pieces. But one of the things that we have done has been try to bring the real stories of young women like this to the table in our conversation. I found that I'm not going to win you with numbers at this point. And especially in instances where I can't prove my data, you know, I really work to just bring real stories to the table. These are real people. This really happened, and actually hearing those stories. And I found that's been a bit more successful, and we are working on that. We did just release a 14 credit CME through ACOG, which actually addresses just breast cancer in young women,
Wow.
and also has a module in there that speaks specifically to young African American and minority women, because we know that they are in some instances not getting the standard of care. And addressing the issue of maybe it's you don't know what the guidelines are, maybe it's you have your own personal biases that you're not necessarily in touch with, you know, but whatever those things are, you know, we talk about that in this module. And that's been, you know, something it's taken us a while to actually get out there, but now we're really starting to try to promote that. But I'm also looking for ways to really be able to help young women tell more of these stories in the spaces, right? Because it's the spaces where your stories are told that are key, and help them tell some of their stories in the spaces where changes and changes get made, you know, and not just policies in terms of legislation, but policies in terms of clinical policy. You know, how ACOG directs their physicians, how ASCO directs their people, how, you know, the societies for nurse practitioners and physician's assistants. And, you know, what we learned was that there's just a broad spectrum. It's not one size fit all for clinicians, you know, so trying to get into all those spaces is probably our next big thing. But thank you all for sharing your story. I think every time I hear one of these stories, I'm definitely bothered and, you know, reminded of why we do this work. Yeah.
I was going to ask you that, Dr. Fairley. I was going to ask you your why. How did you get
Yeah.
into this work, and what's your why?
Yeah, you know, I wandered into this work because I was really interested in what kind of in cancers that were happening in younger people, but that were normally considered screenable cancers. So I started out with colorectal, and then I got to breast, and you know, and timing just happened, and I ended up in this. But since then, I have a strong family history of certain types of cancer, specifically prostate and ovarian, you know, and so since then, those kind of things wandered to light because, you know, in an African-American family like mine, these kinds of things don't get talked about. Ladies' cancers do not get discussed. And so we finally had some of the ladies' cancer discussions that kind of prompted me that, you know, my risk may actually be higher than I thought. Based on my own family history, and that ovarian cancer kind of triggered some things in my own eyesight. So I see it through a different lens now, but honestly, just the stories of, I can't tell you how many stories I've heard from young women at various stages of treatment and care, and heart-wrenching stories. You know, I haven't, you know, I've heard Shanta talked a little bit about some of the fertility pieces, but, you know, hearing those stories about young women who were not told prior to their treatment that there could be fertility challenges. You know, every time I hear that story, I'm actually angry when I hear that story, you know, but those kinds of things are happening. Also, when I look at the data that still says that young African-American breast cancer survivors may or oftentimes aren't getting the survivorship care post-treatment. So access to mental health care, because, you know, cancer can be traumatic. Cancer treatment certainly can be traumatic, you know, and giving the appropriate care on the back of that. Those kinds of disparities are really hard. And I think a lot of people where I work are really attentive to that right now.
Especially at this age, you know, especially at
Yes.
19 and
At 19.
21 and 25, you know.
Yeah.
I've actually been doing a lot of research this summer about like mental health quality post treatment. because I feel like a lot of people usually just focus on the patient while they're actively going through treatment.
Yep.
And I feel like they kind of forget about the patient after treatment. And
Yeah.
my research has shown that like 0 to 2 years after finishing treatment is when people suffer the most, like
Yeah.
mentally, and they actually do get mental health diagnosis from their treatment, from their experience, their cancer journey.
That fear
So I
of
find that
even it
really
coming back.
interesting.
Yeah.
If there's some
Right.
data,
Absolutely.
even 5 years out, something like 60% still have, issues, mental health issues. So
Yeah.
definitely a thing, you know?
So it's PTSD, it's anxiety. I
Yeah.
think there was an
It is.
article, Dr. Laura and Dr. Agori, you might have read this. I want to say, and Dr. Fairley too, it was in, I think it was in JAMA, but it
Mhm.
looked at the quality of life scores in young women diagnosed with breast
Oh, yeah, I
cancer.
saw that one.
Yep, yeah, Shantae, you too, right? So depression, anxiety, body dysmorphism, issues with intimacy and sexual dysfunction, right? All of these things
Yeah.
that, it's not just about being grateful to be alive at this
Right.
point.
Right.
It is really about what is the quality of your life and how can we improve that for you, and making sure that beyond the clinical exams, beyond all the doctors that you see, because when you reach a certain point, you may not see as many physicians anymore, but then what?
Right.
One of,
Exactly.
one of,
Sorry, go ahead.
no, one of the concerns that I have is that the paternalistic feel that people have about my quality of life, that they know what I want out of the quality of my life.
Mhm.
My quality of life is my goals are very different than I'm sure somebody who's 70, who is the
Right.
normal age
Mhm.
group of this. I want to be as aggressive as possible because I have an 8-year-old. I want to see my son graduate from high school and college. And so my level of aggressiveness is 10, 12,
Right.
out of scale of 1 to 10. So I am willing to do whatever it takes to be alive. And that is not everyone's perspective, but I find that sometimes in the medical oncology sphere, that people don't allow you to want to feel that way, to
Yeah.
want to be aggressive. I actually had a second opinion at a major facility in the United States. And within the first 20 minutes, that person told me, we're going to have to make a decision about when you're going to stop your care.
Oh, wow.
And I think I was being too aggressive, saying, can I have surgery? Because this was really early on, and I had one small lesion, and I was like, what are our goals? Can we think about this from a different perspective?
Mhm.
And I think for that person, their thought was, we'll just take it as it comes. And that is not my quality of life expectation. And one of my concerns is that, especially for young women, that the quality of life is thought to be the same as anyone else. And that is absolutely not the case. And oftentimes are not heard and listened to when we say, I want to be aggressive. I'm like, oh, it's almost like a pat on the head. I hear you. I hear you. But no, you don't hear me, because I'm willing to do whatever it takes. And my quality of life doesn't mean that I might not have a neuropathy. If I can trade a neuropathy for 5 more years of life, I would do that.
Right.
And so I think that understanding what that quality of life means and how do you hear that from a patient, and you honor that in the way that it should be,
Right.
is really problematic for Black women.
I love that you brought that up. And I think by the same token, every woman's cancer and their journey and their goals are unique. And how often does a physician sit down and say, okay, what are your goals here? And I'll give you an example. I saw a woman who was 27. She was diagnosed at 29, diagnosed at 23. And her oncologist actually de-escalated her therapy. They did some genomics, some tumor studies that, and those studies didn't include 23-year-olds and many of those,
Right.
those assays that look at chemosensitivity and things like that. And they decided to de-escalate her therapy. And, we talked a little bit about that and what does that mean for her. And it's so interesting how there is no one size fits all approach, but how often do we, Dr. Ogori, how do you have that conversation with patients about their wishes and how important is that? And how many times do you maybe see somebody for a second opinion who didn't get that conversation?
Right. As I'm listening to everyone's story this evening, the key thing that jumps out at me and what I try to convey to my colleagues and even to patients I see is the importance of individualized medicine. It's not one size fits all. We're not, it's not a cookie cutter form of treatment when we're looking at women with breast cancer, women with, any breast complaints, period. I've been working in Newark, and Newark is, for those who may not know, over 55% of the population in Newark self-designate themselves of African American or of African descent. And about maybe 80% of the population in Newark are collectively non-whites, so including immigrants of all different ethnicities. And just working here over the past 10 years, particularly when I was at University Hospital, where I was actually able to query the data over the past 20 years, 15, 20 years prior to me even arriving in Newark, it was consistent even up until this point. Over 20% of our population of breast cancer patients in the Newark, New Jersey region were under the age of 45.
Wow.
And of those under the age of 45, 20%, 70% of them were under the age of 40. So
Say that again.
So in the Newark, New Jersey area, just querying the data, the 20% of the population of breast cancer patients were under the age of 45. And of those women who are under the age of 45, 70% of them were under the age of 40.
That just blows all the screening guidelines.
Exactly. We
right out of the water.
presented that data at, American College of Surgeons, ASBS, and everyone's like, oh, wow, oh my goodness, I can't, imagine. And I said, yes, but this is actionable information.
Exactly.
Okay, which means that it is a sense of urgency in our community, because of course, when you look at the national statistics, they say, oh, breast cancer in young women, only about 7%, maybe 10% of breast cancer patients are young or premenopausal or under the age of 40 or 45. So once you have that low number, it almost diminishes the importance of breast cancer in young women. But I said, but what about breast cancer in young African American women, young minority women in our communities? And we all know with all kinds of illnesses, not just breast cancer, just health-wise, the illnesses in our community are always that much worse, so we have to bring more attention to it. So just when I am, in front of my patients, they're always, I guess, almost like a sigh of relief, because as you said, I do see a lot of second opinions, because a lot of us as women are becoming more empowered with our own healthcare, which is fantastic.
Yes.
And when one person or one physician tells them, no, it's okay, you're young, it's probably, just hormonal, or it's around your period, that's why it's lumpy, that's why they insist they know something's wrong. And when they come to me and I go that extra mile just to do further investigation, there's a sigh of relief.
Peace of mind.
Sigh of relief. And I try to convey that to my colleagues, that look, I understand that the national data or statistics tells you one thing, but we have to cater to the community in which we serve. And we can't ignore what we see. We have to educate our fellow providers that breast cancer or breast disease presents itself differently in communities of color. We have to educate our patient populations about the importance of self-breast exams, because, of course, we can't, really screen with mammograms under the age of 40 unless it's documented family history, or we're saying we feel or see something abnormal, and even then they have to be at least 30, or you're fighting with the radiologist
Uh-oh.
some kind of
There we
imaging,
go.
someone in their 20s, and do, just start with an ultrasound and, all that pushback. But we have to somehow convey to our colleagues that, look, if you're going to treat women, even men within the communities of color, you have to appreciate and understand that disease processes can and oftentimes do present differently and can present at a younger age. And that's really, the reason why I stepped away from academia. I wanted to go more into community health, national health, and patient education and community education, because we have to educate ourselves. Of course, you can't force a physician to do something that they don't feel is right within their own realm. But as individuals, we have to empower ourselves and basically force the issue. Just like if you feel something's wrong and you know something's wrong, until you get that answer that you're satisfied, you don't stop. And the more we educate people in our communities about those things, I think, the more the status quo will listen and understand that on a more systemic platform, we can start changing policies that are geared more towards our community.
Exactly.
So I hear you saying representation matters.
Yes.
Right, as if we didn't already know it, but representation matters, not just in providers, but also in research, right?
Right.
And not just in age, but in race. So
Right.
the data, Dr. Fairley, you talk about the data is not there. Well, why? Because we got to do the trials that look at these things. Most of what we offer breast cancer patients is very poor data for premenopausal women. And for those who are premenopausal, how many are under the age of 40, right? What can we do to increase the data for these therapies and for these qualities of life for our patients, and it's really something to consider, and Doc, I love how you talked about going back to your community and going into the community, because the beauty of being breast surgeons, and Dr. Lori can chime in with this too, is that we can still participate in clinical trials and in research, even within those communities. And it's probably more important to do so within those community settings, even because that's where the patients go. Probably 65% of African-American patients or Black women with breast cancer get care in their community hospitals. Where many of those trials aren't offered. And so I think it's so important for us to be there. But I hear a lot of hope, and I want you guys to speak to people who are fearful of things like chemotherapy, right? In our community, people hear cancer, Black women hear cancer. And I just talked to a young woman, she's 37, last week, and she's not putting those toxins in her body. She's not doing this. She's picking and choosing, from a menu of things and deviating from the standard of care. And it's okay, I guess, to have, the autonomy is important, right? To be able to make up your mind and do your research. But I think there's a lot of fear for people watching about going through this through. And I want you to talk a little bit to some of those people who are really challenged and have created a roadblock for themselves and won't consider certain therapies.
I could chime in real quick. So fear is like our biggest enemy, right? It prevents us from doing things, and also just secret holding and saying oh, I don't want anyone in my business. I don't want anyone to know. And so that's a part of fear, and that uncertainty, right? When I was diagnosed, I still didn't know what was going on. I was Googling everything. I was scared. I was worried. Waiting for the biopsy results is probably the most scariest thing ever. But the thing is, what relieved me was when I prayed, and I prayed to God to relieve this worry, and I instantly felt this sense of calm. And then two, I was like, as long as there's a plan, and with the advanced research of what's going on now, it's just even a difference from when I talked to my older community who've had breast cancer and went through it, and what they went through. They used to tell me stories like, oh, your nails gonna come off and your teeth gonna turn black and things like this. And these things just don't happen anymore because we have so much more targeted therapies, and the therapies are a little bit more manageable and give you a greater quality of life. And I feel that if we have a plan, we can excel, and just don't be scared, because the longer you wait, the worse it could be. And we just want to try to make your life as best as possible. And just like everyone was mentioning about quality of life, I'm a big advocate of quality of life. I want to have sex. How do I do that? You know, I want to still work. How can I manage that? Sometimes I want to drink a little wine. Can I still do that? You know, things like this. And how can I be with my friends? And my immune system is compromised with COVID. What are my risk factors now? And so I just think, you know, you have to encompass your whole entire life and try to reinvent yourself. And that way that you have a plan, it can kind of reduce your fear. Don't be scared. You're not alone. You could do this, you know.
Well, I think one of the things that we're looking at, and this show came about, you know, Dr. Mose, you know, we're doing this HBCU internship program. So it's got under Dewey State. We have 5 interns working with
Yes.
us to try to bring awareness to their campus. And you know, so what do we need to tell them? They're watching right now. What do we need to tell them? And we want to tell them, you know, all the things that you said, knowing you're normal, knowing your her story. You know, we can't prevent it, but we can early detect it, finding it early, advocating for yourself. Like what, you know, we have these HBCU students hopefully watching. Like, I really think that when you go try to ask for birth control pills or birth control, you need to start checking your breath. And so, I mean, I don't think that's medically correct, doctors on the line. So help me with that. But we have to protect our young women and get them aware and give them the knowledge they need so they can be as astute as Ari was to go check herself and go
You
to
know,
and
mhm.
for Shantae to go fight for herself, and even Dr. Lori to know the signals, you know, that she might have been recognized as a doctor, but as a mom she did. So what do we need people to know when they're in college, and what should they be spreading across their campuses today?
It starts before college. And I think understanding that, and by the time you're getting to college, if you haven't had those conversations like I did in my family, you know, we didn't talk about things. It was down there, and there were a lot of euphemisms for body parts that we probably should not have used. You know, the cookie, the this, the that, all these foods and other things. You know, we need to learn how to say the words.
Yeah.
We need to learn how to talk about our bodies without shame. You know, we need to start having those conversations. And I think those interns should know that when they go to the campuses and talk to their colleagues, they're going to be met potentially with some resistance because it's not part of the culture for a lot of us. There is a lot of this sort of, you know, we don't mention those things. And starting to change that paradigm and have these really open discussions about our bodies is going to be super important for them to start to break that cycle, because we need to be starting at 10, at 9, at 8, learning what your body should feel like and getting in touch with your body. And I think that's, you know, that generation are going to be the ones to take that message forward. And so that would be my hope for the interns.
Yeah.
I would like to add on to just realizing that you have to know your body. You know your body the best out of anyone else. And if anything seems abnormal to you, I would just go get it checked out, even if it's the slightest thing. You know, that early detection is the best detection. And I also think just hearing the statistics that we heard tonight saying that like African Americans, women die the most from breast cancer, I feel like that's also just a real warning sign that like our people are not going out there to go and get checked up, or they're resisting their treatment. And I have only treated a handful of Black patients myself, and this is my 3rd clinical rotation, and I've seen under 10 patients before. And so that just lets me know that my people are not going out and going to get checked and taking things seriously. So I would just say the statistics and the warning signs are my biggest message for young people.
Can I'll jump in with when we talk in a little more detail when we say know your body, know your normal, that what we're really saying is know what your breasts normally look and feel like. You need to know what it looks like on your period, feel like on your period and off your period. You need to know throughout the month if your breasts change, because breasts do change according to hormones over time, right? So you need to know what that looks like. And if that means feeling them, I mean, there's no other way to do it really, but you know, you need to take care of that, ladies, right? But it's really important to know what your normal is, because when abnormal shows up, right, you're more inclined to recognize it, and hopefully, you know, more inclined to move on and not let anyone tell you, right, when you know something is off. Like you know your body, as Ari was saying, you know something is off. If the first doctor doesn't work, go to a second doctor, right? Second doctor doesn't work, go to a nurse practitioner.
Say that
Okay.
again.
See-
Say it again.
See
Best
the on-campus,
practitioners.
see whoever you have to see,
Yes.
right? Because you know your body.
Right.
Yeah.
You know, it isn't right. It doesn't feel right. And you know it in your spirit and your gut, you know?
Let's talk about nutrition. Let's talk about the things that we say to our families and to our kids, about exercise, about eating right. I feel like we could start younger, really emphasizing the individual responsibility to start to make these habits, right? For exercise and for wellness. And I feel like it starts a lot later for us than it does for certain other groups. And how can we combat that? Why is that? What should we do?
So,
Oh, I'm sorry. No, that's a great question. And I just wanted to interject because to add on, a lot of the women who I see who are diagnosed with breast cancer, young women, most of them, like we mentioned before, don't have family history. They
Right.
don't have a genetic mutation. It's sporadic, it's random, it's quote unquote coming out of the blue. So we have to talk to young people and, women of all ages alike, things that we could control in our lives that can help minimize our
That's
risk
right.
of developing illness and cancer.
That's right.
And that starts with our lifestyle. So from very young, we have to emphasize to our children, our siblings, our parents, our family members, that what we ingest and what kind of physical activity we partake in or not partake in has a direct correlation with our health, our overall health, including, cancer. Because we still don't know why, people are getting cancer now. Cancers across the board, breast cancer, colon cancer, lung cancers. We're seeing patients presenting at younger and younger ages. And this is even going across, white and European American people.
Yep.
So we really don't know what the cause is, and we're just attributing it to possibly something environmental. So I 100% agree that we should try and be more cognizant of what we can control ourselves, which is what we do, what we eat, and how active we are.
Right.
I was,
Yeah, I was gonna throw in there that when we're talking about what we put in our mouths, it's not just food, but it's also what we drink. And so alcohol, as much as hard as it is for us, I'll say it, right? Alcohol consumption has been connected to breast cancer, right? And so, binge drinking, right, is a problem. I actually have the data to back me up on this one, so having more, I think it's more than 1 drink a day for women and 2 for men or something like that. I can't remember the exact number, but excessive alcohol consumption.
You're right. It's 2 drinks a day for a man, 1 drink a day for a woman.
Thank you.
Boom.
Less
Way to
than
back
5
me
a
up.
week, less than 3 ideally. That's right. Yeah,
That's
people
right.
hate to hear that.
Yeah, and so those
it's
party
true.
nights where you have 5 drinks a night, yeah, can we, we want to try to like turn that down a little bit, but we don't talk about it a lot. We've started trying to push the message from CDC, but it's a difficult message for people to hear. People don't want to hear that alcohol has been connected to cancer, and especially connected to breast cancer, but it has been.
yes.
Colon cancer, pancreatic,
Yep.
prostate, esophageal, you name it, and
It's a carcinogen.
alcohol. But that's a
Yeah.
great message for our interns as well, because on a college campus, what happens, right?
Yes.
Yeah.
Now, I get the question all the time from my young people too, is, well, can I just save them all up for Saturday?
Mhm.
Average it out.
I tell my patients to pour theirs to pour it at the beginning of the week. If you have to have alcohol every night, or and for my
That's it.
cancer patients, I like for them to have less than 3 drinks a week.
Right.
Yeah.
And so I say measure it out at the beginning of the week, and that way when you're all done, you're all done. And I encourage them to do a lot more spritzers, put some fresh fruit. Let me get some antioxidants,
Yeah.
maybe some raspberries and cherries, and kind
Yeah.
of make some fun cocktail sorts of drinks where you can still be social but decrease the alcohol intake. And the other thing is with respect to fruits, and vegetables. The data that I've looked at shows
And
that
carrots.
you've got to start younger, and it's a cumulative effect of all of those foods that helps our bodies to fight through increasing the ability of the body to destroy damaged cells, right? Because that's what cancer is. It's a cell that becomes forever. It's a damaged cell that then reproduces and reproduces and reproduces. But our body has these intrinsic mechanisms to heal itself, to start to recognize some of those things. And I think that it's so important for us to start putting that stuff in and storing that up early, because as we get older, we're more likely to make more cellular mistakes.
Yeah.
And so talking to young people about nutrition and about wellness and about, learning to eat from the earth, right? And how our food is
Yes.
medicine are all things that we really have to get in touch with. And so, Shantae, I want to see you have some college kids out there on the farm. I'm gonna bring them
Yes.
out to my farm too, because you guys
Yes.
help me get mine together.
Let's
And
go.
we're gonna get these HBCU students on a farm tour,
Yes.
right?
Yes.
And that'd be
Can I
incredible.
come?
Please.
You are cordially
I will help
I just-
delegate. I will
Please
help
come.
delegate, observer.
I did want to add one thing. Like in college, I swear I'm probably was like ahead of the curve. In college, I did like a presentation about environmental factors that have carcinogens in, right? It was so shocking to everybody, like your deodorant, the aluminum in it, and like the lotion that you put on your skin. And it's not always, the food. It's also what you touch and what you put on, and like what's in the fabric and the paint in the walls and things like that. Environmental factors like red meat. We eat so much beef cheeseburgers all the time, but you need to reduce that because it has a carcinogen in it. And, nitrates, like those deli sandwiches, maybe you could get the non-nitrate type deli sandwiches. And I know it's a financial thing too, because we just don't have it, especially if you're young, and you do the best that you can. But if you cook better and more at home, the better quality foods you can have in your system. And you don't have to go extreme. And if you want to see a therapist, when I first got treated, since I'm estrogen positive, I just knew that soy was going to get me and edamame was going to get me. But I spoke to a oncology nutritionist, and she reassured me. She's like, you can have your edamame, it's
Right.
fine. It's the soy protein that you need to be mindful of. And I was like, oh, okay. And I love meat, I do, but I've reduced it. But I drink a smoothie every day. It helps with my immune system. All the darker vegetables and fruits has a lot of beta carotenes in it that helps increase the antioxidants and fight things. And I swear that helps my numbers. I have facts that it helps my numbers, because my immune system be bad when I don't drink my smoothies, and then it's like awesome when I do drink my smoothies. So
I love it.
I just wanted to add that.
I got a slide on that, all the different foods, the different berries, different things that will boost your immune system and fight cancer. I'm going to put it in the comments because I think that people are always asking every week about nutrition, about prevention, about ways to boost your immune system. So, all right, look at your background. What'd you say?
Okay, trust your intuition. All right.
Yes.
Yeah, I really like that. It goes with the theme.
That's bad. That's badass.
We should put a page on our website about, what to do when you're young. So we're gonna put I'll get our HBCU interns to work on that, but we'll get them to work on that, and we'll put some resources together for everybody. But you guys are like amazing.
Incredible.
Nature.
Can I throw one last shot in there for family history? I think we've talked about family history with some folks here having family histories, but since we're talking to college kids, like really finding out from your family what your family history of cancer is very important, right? And I know we say, only 20% have a family history, but if you're a part of that 20%, then that's going to be an issue for you down the road, and so finding out, who in your family has had cancer, what age they had it at, because that's very important. If you had any male in your family who has had breast cancer, you're at higher risk. If you've had females diagnosed before the age of 40, you're at higher risk, but learning those kinds of things and actually, and it may be hard, it was hard in my family, having that conversation. I think Dr. Mo said, say the words, right? So like saying the words, with your family, you might have to say the word cancer, or talk about lady parts or down there or cookies or wherever, but to get that conversation started, because most people with a genetic predisposition are diagnosed younger,
Yeah.
fill in the cancer, but they're
And I-
diagnosed younger.
Yeah,
I
I have
promise you, that
a,
is not the reason that your children are maturing too fast. It's not because of that conversation.
Right.
You know, that
Mhm.
conversation will help to balance out some of that maturity, because they'll be able to be more in tune with their bodies and what they like and what doesn't feel good and what's not
Yeah.
appropriate. And, you
Mhm.
know, like those are all things that we need to talk about in our community. You're right, Doc.
yeah, I have a genetic trait for colon cancer. And I only learned that through when I got genetic
Testing.
testing,
Mhm.
when I got diagnosed. So now I have to get a colonoscopy every 5 years, which I'm going Friday to get my one for 5 years now. Thank God I've been here for 5 years so far. But yeah, that was interesting. So now I tell my family, make sure you guys get screened early.
But I also think there's some gene stuff about Black women that we don't know about.
You
either.
don't know. That's right.
Yeah.
Yeah.
That's true. Dr. Gore, talk about high-risk programs, and Dr. Lori about knowing your family history and doing genetic counseling and testing. 'Cause I'll tell you, a lot of older Black women, they weren't offered that opportunity, right? They got diagnosed at 40, at 35, at 45, at 50 with triple negative, and nobody
Absolutely.
tested them. And we can go back now and we can test these women. and
Oh
we can screen
yeah,
them.
oh yeah. It's amazing how many women I see who just come to me because they know I'm a breast surgeon, just for follow-up and maintenance of care. And they tell me, oh yeah, I had breast cancer 15 years ago, 20 years ago. And I do the math. I'm like, wait a second, how old were you? And oh, I was 35. Or oh, I was definitely they give me an age that's under 40. And they were following a doctor or primary care or someone who should or would be the one to do or even inquire about genetic testing. And I asked, well, were you ever offered genetic testing all this time? And patients, most of the time they would say no, but a few of them actually said, well, when I asked about it, I was told because I'm not Jewish that I don't need it.
Wow.
So, I find I'm testing women who've had cancer 20 years ago at age 35 or 30,
Yeah.
Granted, they may not have, a BRCA gene mutation, but they may have some variants of uncertain
Mhm.
significance or
Mhm.
something that raises an eyebrow and could potentially be something in the future, because this is like an evolving sort of, world studying genetics and the relationship
Science, yeah.
which gene causes cancer. But it falls back into the difference in care that African Americans in general are offered compared to, our white counterparts. And unfortunately,
Yes.
it, trickles down to cancer care as well. And even just, surveillance, screening, and the adjunct treatment and care and analysis that comes along with cancer. So absolutely, a number of our women are not offered genetic testing and genetic screening as often or as much as they should be. And there's still this bias that Black women or, women of color do not or will not have any kind of genetic mutation, which is, it is a false, statement. It may not be as much as a white person, but it definitely does exist because, I have diagnosed women with genetic mutations. We have, Ari saying she has a genetic mutation. So it does exist within our community, and we definitely need to test more.
Wow.
And I think that when we begin to look at where our support needs to go educationally, we have to understand that representation matters. Only about 3% of genetic counselors are actually Black in the United States. It means that many of the long-held thoughts about what genetics is for Black people is misunderstood, and that there are oftentimes biases that go along with that. So making sure that those programs are sponsored in areas where we know that those that are going to go back to their communities and serve. We have an amazing young woman who's at our institution, and I can count on one hand the number of times someone has turned down being genetically tested when they've gone to her. I think that it is about your approach, about your understanding of the community and who you're serving. And what we have found is that when it's done in a very approachable way, and that things are explained to the advantage of the patient, that they are often more likely to do their testing. And for that, we have seen a lot of variants of uncertain significance, and and we don't know what that means yet. But at least we know that they're in the database, and that ultimately we will begin to hopefully see that. One of the things that we're moving to next is next generation sequencing, and making sure that that's an option for Black patients as well, which allows us to look at the genetic abnormalities, whether they're somatic or not, and being able to target those patients, for instance, that are metastatic, and are there differences in the targeted therapy that they may undergo, and having that option of having the reason why I joined a clinical trial was because I underwent next generation sequencing, and I found a target that actually two targets for me that I would not have had in standard of care. And so it is uncommon for Black women to be a participant in clinical trials, and then more uncommon that they have the advantage of using these newer technologies.
Wow.
Oh, absolutely. It's going to be exciting to see in 2021. I think many of the genomic companies that look at hereditary cancer risk are coming out with all sorts of global and more diverse risk scores. They are doing next generation sequencing, but also looking at the SNP analysis in the hereditary mutation. So if you don't have a mutation, what's your cancer risk just based on the genes that you do have present? And looking at that for Black and brown women is going to be so important, I think, because we know that as of right now, the data shows only 5 to 10% of our cancers are hereditary, right? We have the same rate of BRCA mutations as others, but there's got to be something else. And
Right.
so looking at the SNPs, right? Looking at those parts of the gene and the ways in which they're expressed, looking at methylation, all that stuff is going to be so interesting when we finally do it on Black and brown folks. And it's exciting to think about. Sorry, Rick.
Right. And being able to bring it to patients and have it be economical.
Yeah.
Right.
That it's not something that is going to be thousands of dollars. Actually, next generation sequencing is for most about $100 when they are under the poverty level. So I think that it is definitely doable. There are lots of things that are available. We just need to be asked. Number one, we know that is number one. And number two, we need to have the advocacy that we are providing, so that we bring this information in a very reliable way so that patients understand and know what they can expect to get when they're going. And I think one of the last things that I would push is that there are guidelines that are based in data of how we should manage patients. One of the things patients should know is that those guidelines should be for them too. That they should be individualized for each and every one. And so those guidelines that they may not know, they need to ask, are you using guidelines? What guidelines are you using to manage my care?
Right.
Yes.
Wow. Wow.
Because we know that many patients, we just heard about the de-escalation that, oh my gosh, we see, I'm sorry, this is a hot button for me, of course, but, we see patients that oftentimes African-American that have lower white blood cell counts. And so then they get their medications or their chemotherapies get changed because they're, for whatever reason, the thought is that, oh, well, they're neutropenic or, whatever. When in actuality, when you look at those statistics, we are low to begin with, and it's really not something to change our chemotherapy regimens over.
Wow.
And so all of that happens all the time. And I just want to make sure that we're doing the right things for ourselves, and we know to ask, well, why are you changing my chemotherapy? Is that what the guidelines say should happen? And so we should just educate ourselves.
Right, right. Guys, we could go on all night, you guys.
Absolutely.
This is so rich,
Do
isn't
it
it?
again. We'll just have to do it again, okay? We have to do
Yeah,
it,
this is great.
do it again. So thank you so much. You guys are just amazing. And we have a lot of work to do. We all have to, we just have to keep fighting like girls every day and do this work. And so thank you for all that you do. And we treasure what you do. And we'll get back together again. We need to keep talking about this. And I hope our HBCU students are watching and listening and hearing all this and getting it. And text us, call us. You know how to find me, Ricky at touchbbca.org. Put it in the comments. We'll reach out to you. And everybody want to give who they'll call, how to reach them. And Harper's squeaking a toy.
I just want to say thank you to everyone else. Y'all's stories is amazing and it's so surprising. And I'm glad to know that I'm not the only one out there doing this whole thing by myself.
We're all here with you.
Nobody does it quite like you do, Ari. There's such power in your stories, and I want people to know that too. If you're watching, that this is happening to you or it has happened to you, your narrative and your stories have so much power. Dr. Fairley, I think you said it, really best, but we don't always tap into that. We just keep moving forward. As Black women, we have so much going on, and we don't tap into the strength in that. So I think talking about that and telling people about what's happened to you and how you've overcome and where you are, even if you're metastatic, looking at these women are vibrant and thriving and doing amazing things, right? This is not a story of defeat or of anything else. This is like, I got stuff to do. I got kids to raise. I got gardens. I got bees to keep, and I'm loving that. That's what I get from this. I'm an optimist, and I just feel so optimistic when I hear these things from you, because people look at your stories and think the worst, and I want them to think the best, because we have to maximize whatever time we have on this planet and execute our purposes. And so, Shante, how can people reach you? Ari, did you tell us how we can reach you and follow you on social media? We'll go Dr. Ogori, Dr. Lori, Dr. Fairley, and we'll wrap it up.
Well, you can add me on Facebook. My name's Ariana Apodaca, or you can follow me on Instagram. My name is Mama Ari. Yes, I feel like I'm at least 47 years old in my soul. So, no, literally, 1973. That should have been my year. But you can follow me on Instagram, Mama Ari, spelled MOMMA _ Ari, ARII. That's my Instagram.
I mainly hang out on Instagram. I've been on Facebook since the beginning of time, so I transitioned a little bit more, but I'm on both, but mostly on Instagram. It's Shante19, that's SHONTE19. And if you want to follow my farm, it's Curemore Farms, that's CUREFARMS on Instagram.
Beloved, your farm has its own Instagram. You go, girl.
Yeah. People asked me to.
Yeah. And I just joined Twitter. So I'm Dr. Lori _ HBC unit.
I'm on most of the platforms as at Dr. Tamika. So that's my first name, TEMEIKA. It's Dr. Tamika.
All right, I'm Dr. Monique Gary on Facebook, the LinkedIn, the Twitter, the Instagram. I'm so old, I put a "the" in front of all of it. You can find me. I'm always with Ricky joined at the hip for Touch BBCA as well. And we just are so grateful that you guys would be here. Dr. Ogori, did we get you yet?
You get hers.
No, so I'm an old soul. I'm just on one platform, and that's LinkedIn. You can find me at Ogori Kalu MD at LinkedIn, or just email me directly, onkalu@gmail.com.
Awesome. You're going to get some second opinions for sure from this. I am certain that women need to find you. They need to see you. Dr. Lori, they need to see you. Dr. Fairley, we need to know about that research and how to get involved, because I think this is a turning point for Black women in cancer research as well. We are
Yeah.
really ready to become much more invested than ever before in what's happening to us. I think coronavirus has sealed that deal, and everybody knows Black Lives Matter, but, for us, we're tired of being a poster child for everything.
Right.
The worst of everything.
Everything.
You know,
I got two more things before we
go
sign off.
ahead.
So every day at 3:00, we are doing a dance party. One song. We're putting the link in the chat. Come on Zoom with us and dance. One song, 5 minutes for bone health. We're moving for bone health for our partner Amgen, and we're doing it every day, every weekday at 3:00, and we're planning our Halloween walk. So we're gonna put we're gonna bring your dog, put your dog or your cute kid, your cute dog, your cute honey, whatever, in a costume. We're gonna do a Thriller dance contest on Halloween morning. So all the details are on our
I'm
website.
Michael Jackson's #1 fan, so if
know.
y'all want to fly me out to do that Thriller dance.
On Zoom, you can lead it, girlfriend. You can lead it. All right. We have so much stuff going on. I can't even go there right now, but check out our website. We have our event page. We have also our social media, and we're trying to do a lot of stuff, save lives, do some good stuff. So thank you.
Well, we hope this has been relatable and reliable and real. That's what we set out to do every single Wednesday night and Sundays in October. Next Sunday, our topic is
Bone health, bone health,
home health.
bone health, and walking and dancing and moving and keeping your bones healthy and strengthening your bones. And that's why we're dancing every day. But we're gonna have some good talk about how to stay healthy.
I love it. Well, we will see you guys next time. Relatable, reliable, and real. The doctor's in. Thank you so much for joining us.
Resty love.
Bye, y'all. Bye.
See you guys.
Bye.
Bye.